viewers. I hope you might be watched about my last video. It was precipitated labor. In that video, I promised you next class will be prolonged labor. Yes, today's our topic is prolonged labor. Before moving to the definition, it is very important to know the normal labor progress. It can be divided into three ways: latent phase, active phase and second stage. In case of latent phase, up to 8 hours in case of nulliparous and 6 hours in case of multipara. In case of active phase, the dilatation will be at 1 to 1.5 centimeter per hour. When it comes to the second stage, 30 minutes to 2 hours in case of nullipara, 15 minutes to 1 hour in case of multipara. So prolonged labor is a deviation from this expected course. Here we'll explain about the definition of prolonged labor. Prolonged labor is when the progress of labor, which includes cervical dilatation, effacement and descent of the fetus, is abnormally slow. According to WHO in 1994, in case of primigravida, it will be more than 12 hours. In case of multipara, it will be more than 8 hours. According to American College of Obstetricians and Gynecologists, which says prolonged latent phase 20 hours in nullipara and 14 hours in multipara. On the basis of protracted active phase, the cervical dilatation less than 1.2 cm per hour in nullipara, less than 1.5 cm per hour in case of multipara. When it comes to the arrest disorder, it can be divided into two: arrest of dilatation and arrest of descent. In case of arrest of dilatation, no cervical changes for more than 2 hours despite adequate contraction. When it comes to the arrest of descent, no descent after more than 1 hour of pushing. The last we will see about the prolonged second stage. In case of nullipara, it will be more than 3 hours with the epidural and more than 2 hours without epidural. In case of multipara, it will be more than 2 hours with epidural and more than 1 hour without epidural. So, on the basis of all courses, we can define prolonged labor. Next, I will explain about the etiology of prolonged labor. The etiology of prolonged labor can be defined on the basis of classic framework of 3 P's. The 3 P's are power, passage and passenger. First, we will see the causes of power. The first one is hypotonic uterine inertia. Second one is hypertonic uterine action. Third one is incoordinate uterine action. And the last one is precipitate uterine action. When it comes to the hypotonic uterine inertia, the contraction will be weak, short and infrequent. When it comes to the hypertonic uterine action, there will be excessive contraction but uncoordinated. In case of incoordinate uterine action, there will be irregular contraction pattern can lead to ineffective labor process. So the last one will be precipitated uterine action. Sometimes it causes obstructed progress if combined with the malpositions. Next, we will see the causes under passenger, which include malpresentation such as brow, face and shoulder. Next will be malpositions such as occipito-posterior and occipito-transverse. Next will be fetal anomalies such as hydrocephalus, conjoined twins. And last one will be macrosomia, that means fetal weight more than 4 kg. Finally, we reach the cause under passage. The first one is contracted pelvis. So here the true conjugate will be less than 10 cm and interspinous diameter will be less than 8.5 cm. The second one will be cephalopelvic disproportion. The third one will be soft tissue obstructions such as pelvic tumors, cervical fibrous ring, rigid cervix in elderly primigravida, full bladder or rectum and perineal rigidity. So these are the causes of prolonged labor on the basis of 3 P's. Here we reach the pathophysiology of prolonged labor. Whenever there is a delayed progress in labor which cause uterine muscle fatigue, Also, it lead to contraction weaker. Ultimately, it can lead to maternal exhaustion from long painful labor with dehydration and ketosis. Fetal hypoxia can be developed due to prolonged compression and reduced placental perfusion. Also, there is increased chance of getting mechanical trauma to mother and baby. This is the pathophysiology of prolonged labor. Here we reach the risk factors of prolonged labor. First one is primi gravida. Second one is teenage pregnancy. Third one will be elderly primi gravida. Next will be short maternal stature, pelvic deformities, maternal obesity and diabetes, multiple gestation and inadequate uterine contractions. Next we'll see about clinical features of prolonged labor. In that, first one is history. In the history we can identify prolonged duration since onset of contraction and increasing maternal distress and exhaustion. In case of general examination we can identify tachycardia, dehydration, fever, ketotic breath, etc. In case of abdominal examination we can found poor progress of head descent, abnormal uterine contraction and fetal heart rate abnormalities also. With the help of vaginal examination, we can identify slow cervical dilatation, malpresentation or malposition, caput succedaneum and molding of fetal head, and assessment of pelvis for disproportion. Next, I will explain about the diagnosis of prolonged labor. In that, first one is partograph. Partograph is the most important tool in order to identify the cervical dilatation, descent of head, uterine contraction, maternal and fetal condition. If labor curve cross the alert or action line which indicate prolonged labor. With the help of clinical examination, we can confirm the causes of 3 P's. Apart from that, we can use ultrasound scan in order to identify the malpresentation, macrosomia and hydrocephalus. Finally, we reach the management aspect of prolonged labor. In that, we will see the general measures, which include admit to hospital, IV fluid to correct dehydration and ketosis, antibiotic prophylaxis if labor prolonged more than 18 hours with a ruptured membrane. Maternal bladder should be emptied regularly and continuous fetal monitoring. In case of specific management, which will be depending on the causes. If the cause is due to the power problem, we can go for amniotomy if the membrane is intact. Oxytocin infusion can be opted, which will be titrated carefully under monitoring. Epidural anesthesia may improve coordination of contraction. If the problem will be based on the passenger, such as malposition, especially persistent occipito-posterior, manual rotation or operative delivery will be preferred. In case of malpresentation such as brow or face, usually we can go for cesarean section. In case of macrosomia or CPD, cesarean section will be preferred. In case of passage problem, especially contracted pelvis or CPD, only we can go for cesarean section. In case of soft tissue obstruction, if it is possible, we have to correct it. Otherwise, we can opt only cesarean section. The last one will be the prolonged second stage. If head low and no CPD, we can go for forceps or vacuum extraction. If high station or CPD, we can opt only cesarean section. I think we can wind up our today's section. This prolonged labor is a vast topic. Anyway, I concised and explained it in a simple way. I hope all of you understood about the topic. The complication and prevention will be displayed on the slide. Please have a look on it. Thanks for watching my video.